Welcome to the Independent Sage Friday briefing. Those of you who joined us last week for our special briefing on global vaccine equality will be familiar with the phrase, nobody is safe until everybody is safe. Unfortunately, this has been illustrated only too clearly this week by the desperate situation in India, which yesterday recorded the highest one-day increase in cases worldwide since the beginning of the pandemic. Over 2,000 deaths were recorded in a 24-hour period, and the country is now facing a humanitarian crisis as hospital beds fill up and supplies of oxygen are running out. It's possible that the new spike in infections there is being driven by a new variant of the virus, B1617, which we know has already arrived in the UK. As restrictions start to be lifted here and a semblance of normality returns, it's clear that we must not allow ourselves to become complacent, either in our attempts to suppress the virus or in the fight to ensure equal access to vaccines worldwide. So today we'll be answering your questions on India and the implication of these new variants. But first, Dr. Kit Yates is the man with all the latest figures at his fingertips. Over to you, Kit. You have got those figures at your fingertips, haven't you, Kit? Here he is. He's coming. I can see him. Well, I think, unless Kit joins us very quickly, we are going to go straight to questions then. And then we'll come back for Kit's roundup of the latest facts and figures later. So if I can invite a question first then from Dr. Duncan Robertson. Duncan, I hope you're there with us. He works in policy and strategy analytics at Loughborough University. Duncan, what's your question?
Well, thank you very much for inviting me to ask a question. The question is, do you think there should be a red list of countries, and how should countries be added or removed from that list?
Thank you very much, Duncan. Who'd like to start with that question then on red listing countries? Professor Gabriel Scally.
Thanks, Duncan. The question, the reason for your question is obvious, because we have a huge problem at the moment with transmission across the world, but transmission moving between countries as well. The position of Independent Sages has been from our earliest times that we thought it was wise to put on public health controls at ports and airports and to limit the importation of the virus into the UK and into Ireland, into the common travel area. And that's for several reasons. One is, at a time, for example, last summer when the virus levels were very low. In fact, Scotland was at elimination level, as was Northern Ireland at that time. We were concerned that not having those controls in place would allow the importation of the virus back into the UK. And that's subsequently what happened with the Spanish variant spreading very substantially across Britain and Ireland from the autumn onwards. And subsequently, we now have a situation where there are a huge number of cases in the world, with mutation taking place, obviously, with the virus and producing variants of substantial difficulty, whether it be the variant first identified in Brazil or the variant first identified in South Africa. Now, the only safe way to do that, to deal with that, and to prevent it becoming, some of those variants becoming a major problem for us, is to put public health controls on our borders. And that means ports and airports, and people coming into the country, instead of being required to self-isolate for a period of time, that should be carried out in a managed isolation situation. And I think our position on that has been borne out by the data which has emerged that indicates that very substantial numbers of people do not fulfill the terms of their self-isolation and put the rest of us at risk. So I don't think that there should be red countries, orange, amber countries, or green countries. We should only have free and open movement between countries on the situation, on the basis of the situation that there is no virus to transmit between those countries, and that is not possible for us at the present time. So we should have controls, I think, in place almost universally, and they should be the same controls, and they should be managed isolation. Thank you.
Thank you, Gabriel. And Professor Stephen Reischer, you'd like to answer this as well?
I just wanted to add, completely endorse everything that Gabriel said, but it's really important to understand that the issue of borders is not an insular, let's stop them coming here and let's protect ourselves from them. I mean, of course, we don't want new variants coming into this country. And there's been a lot of talk about India, but of course, next to India is Pakistan. And Pakistan is also going through a huge spike in infections. At the moment, the health services are in real danger of being overwhelmed. And there are increases in nearly all the states in Pakistan. And one of the reasons for that is because the so-called Kent variant is beginning to gain purchase there. So the point about controlling borders, as I say, isn't just about stopping them coming here. Indeed, it's not also about us going there and infecting others. It's keeping each other safe. So this is not about insularity. It's not about Little Britain. It's not about closing borders for the sake of it. It's about being a responsible global citizen and making sure that we can get on top of the pandemic everywhere. And I think it's really important to stress that point. It's not about insularity. It's about responsibility.
Thank you very much, Stephen. And Professor Martin McKee.
Yeah, thanks. And just to amplify that, something we've said before here, which is that this list of countries is based on an incredibly simplistic model of international travel, where people go from one country to another without diverting. The reality of it is that, of course, they're often connecting through hubs, and they're mixing with people from many other countries in airports. But more than that, when we think particularly about holidays, people are going to resorts where people from other countries will be coming in. So looking at the level of infection in a country tells you nothing about the level of infection in a resort where you have mixing from all over Europe, all over the world. So it's a very naive way, a very naive model of travel, which is completely at odds with the reality.
Thank you, Martin. And Dr. Zubaida Haque.
Well, just very quickly, I want to add, if you look at the red list countries at the moment, it resembles immigration policy more than public health policy. And it's just simply, it's almost color-coded. It is the Asian countries, it is the Middle Eastern countries, it is the African countries, it is Latin American countries. It is pretty much color-coded. And I think that that's worrying. But more than anything else, what's worrying is most of Europe isn't on the list. We have a third wave on our doorstep, and they're not on the list. France isn't on the list. Germany isn't on the list. Canada isn't on the list, and so on. All these other countries that are facing a surge, a second and third wave, are not on the list. And what that goes to show you is it's pointless having a list. The list doesn't keep up with countries. The virus moves when people move, and we simply can't control how people move. We can't control where they're moving. We can't trust that they have said that they've been some places and not in other places. So the easiest thing to do is to have strong restrictions, because as Stephen said, it's not just about protecting us from them, it's also about protecting them, also about protecting other countries from us.
Thank you, Zubaida. And now Professor Anthony Costello would like to comment.
Just very quickly to say, two things that we should be focusing on are improving genomic sequencing around the world, because I think Deenan last week said the variants you get are the ones that are found by the countries that can actually screen for them. So India can do it, Brazil can do it, South Africa. But what about all the other countries that may have variants of concern that we don't know about? And of course, linked to the other thing that we should be really focusing on, as we've discussed before, is vaccine equity. Because until we get the whole world vaccinated so we can really suppress this virus, then you're not going to get rid of the variant threat. So the idea of having red lists and blue lists and orange lists and whatever is not really the scientific way to deal with it. We need to have sequencing all over the world, and we need to have vaccine equity.
Thank you very much, Anthony. And Duncan, you work in policy and strategy analytics. What's your perspective on this?
Well, I think it's just interesting to see how those sort of risk assessments are done. I think it's the Joint Biosecurity Centre that does those risk assessments. And it's kind of interesting to know why they're not public. So if you sort of cast your mind back to last year, when the Contain framework was around about allocating colours to different counties, it was very clear, at least when it started, how that assessment had been done. And it seems, slightly odd that that's not being done this time. And of course, if, in months' time, we do actually have outbound travel from the UK, it'd be interesting to see where the cases are highest and where the risk is highest for outbound travel. And I think it's kind of interesting to compare the UK to the US, where the CDC over there have really said their travel ban list is going to be very much epidemiologically based rather than perhaps up until now being more politically based. So perhaps that's something could be considered in the UK.
Thank you very much, Duncan. Thank you for that question too. And now I'm going to hand over to Dr. Kit Yates for a summary of the latest facts and figures. Kit, over to you.
Great. Thank you, Alice. Hopefully you can see that now. My apologies. We do like to play around with the format a little bit week on week, but that was a little bit too much. My computer was having trouble. But here we go. So, yeah, I'm going to summarise what's going on in the UK and a little bit around the world. In short, cases are continuing to fall in the UK. Vaccination rate has improved after a little dip, but we are still seeing some inequalities in vaccine take-up, both by deprivation and by ethnicity. Looking more globally, we've talked about it a bit already, but the situation in the Indian subcontinent and in South America are extremely concerning. And so this is what I'm going to go through. We'll start with looking at cases and positivity, and then I'll have a look at breaking down cases in the UK by age and talking a little bit about schools as the schools have gone back this week. I'm going to talk about vaccine and vaccine inequality, and then variants, and then finally looking at other countries, the situation in other countries around the world. So firstly, focusing on the UK, looking at cases. These are in green, the number of confirmed cases in the UK by date reported, and you can see that I haven't actually updated that figure, but at least I've updated the most recent figure. Apologies that I haven't put the most recent version of the previous one in, but you can see that actually after a little flattening that we had between around early March when schools went back, things have started to fall again and then flatten off again in the last week or so. But cases overall have continued to fall. Looking at the different nations in the UK, these are cases per 100,000 rolling 7-day averages. Red is England, green is Wales, black is Northern Ireland, and blue is Scotland. And you can see that cases have been falling, apart from in Northern Ireland, where they saw a little uptick in the last week or so, but typically have been falling quite regularly over the last several months now. Obviously those falls have slowed down because we've got fewer cases, but still everywhere is coming down. And then when you look at the positivity rates, you can see that slight blip for Northern Ireland here in the positivity rate. So it seems that it genuinely, cases genuinely did rise, but actually they've started to come down again. And you can see that everywhere is below about 2.5% in terms of positivity. So that's really good news across the different nations of the UK. Looking at English regions, this is cases, again, cases per 100,000. Again, you can see that all regions saw this flattening off that we saw in the UK national trend in early March and across March, and then they've continued to fall again slightly more steeply. So that's true across all regions. Yorkshire and Humber still remain slightly higher than everywhere else, but they are also coming down as well. And then similarly looking at the positivity rates, just to make sure that these falls aren't an artifact of testing, that flattening off in cases is not as evident in positivity, because some of those cases were being found as a result of increased testing, where we ramped up lateral flow testing in early March. And so generally we've been seeing fairly consistent falls across all the different regions in England, and we've seen that this week as well. Just breaking down cases by age, because I think this is interesting to do. For the 60 plus age category, you can see that cases have fallen pretty much consistently since, well, before early February, since January when we instituted the lockdown. It's not quite the same case for the 20 to 60 category, the 20 to 59 category. Again, we saw these sort of slight plateauing in some regions, again, related, we think, to schools reopening, but then we've started to see those falls again. But the really interesting age category is probably the 0 to 19s, where we did see these real peaks in cases per 100,000 across all different regions when schools went back. Part of that, it should be said, is related to testing, increases in testing, but part of it is a genuine rise in cases as children were mixing more readily in schools. So this is the number of lateral flow device tests that were conducted. This is a moving 7-day average, and you can see that it actually starts to ramp up before schools go back, which explains why on the previous slide you actually see these falls stop before you even get to the 8th of March when schools went back. You can see the falls have started to arrest, and in part that's because of an increase in testing. But you can see that the cases then flattened off and then dropped over Easter. If you break down the 0 to 20s into 5-year age bands, so 0 to 4, 5 to 9, 10 to 14, and 15 to 19, you can again see that 3 out of those 4 saw this rise in cases per 100,000. Nursery or preschool didn't see that rise, but then they'd been back since January anyway. As I've said, some of this is due to testing, but then if you look at the Office for National Statistics prevalence survey, the infection survey that they do, which uses randomized testing, so it's not dependent on the amount of testing being done, you can still very clearly see these rises in age 2 to year 6 children, 7 to 11, and slightly less so in year 12. So that's sixth formers or college students up to age 24, including university students. So you can see these rises, but they didn't tend to bleed through into the older age ranges as much as we might have feared about. Okay, so that's about age-related data. In terms of vaccinations, the vaccination program is still going really well. We had a slight dip, especially because of Easter. We saw a dip in the number of vaccines being given, but that has started to rise again week on week. And so we're seeing primarily first doses being given now, primarily second doses being given now. Sorry, that's the orange here. First doses are at relatively low levels at the moment. And that's because we have to keep up with the first doses that we were giving earlier on, 12 weeks before, if you liked it, in order to make sure we give everyone their second dose within that 12-week time frame. Just looking at the proportion of people who've received first and second doses, you can see that first dose coverage is now up at 61% of the UK adult population, and second dose coverage is up at 20%. And so you can also see this flattening off of first doses being given, while the second doses are starting to ramp up. And I guess we will expect to see this trend continue as we go forward. In terms of looking at the different nations, there is a slight disparity opening up. Wales is surging ahead in terms of first dose coverage at about 66%, and Northern Ireland's lagging behind slightly, but the difference is only 10% in absolute terms. So it's nothing to be particularly concerned about. But it's good to see that almost, or in fact, all nations have got above 55% coverage. And then similarly for second doses, this should say second doses on the slide here, sorry, we're seeing that Wales surged ahead, but are now slowly being caught up by the other nations, and we're seeing coverage around 20% for all of the UK nations. So that's really good news. In terms of, this is for over 80s, just looking at first and second dose coverage, the only thing that I think we should be slightly interested in or keep an eye on is making sure that we do keep up with the first dose coverage for everyone, but this in particular is the over 80s who've been given the most second doses. So this week we've got 83% of over 80s who've had 2 doses. whereas 12 weeks before we had 80%. So we're 3% ahead of where we need to be. But last week it was 59% compared to 75%. So we were 16% ahead of where we needed to be. So as we're going forward, we just need to be careful that we are still making sure we keep up with the first dose schedule, which indeed did go very fast at this period. But we need to make sure that obviously over the next week, we give at least 5% of these second doses to make sure we're keeping up, making sure everyone's getting their second dose in a timely manner. As well as vaccine coverage, perhaps one of the more concerning aspects is inequality in vaccine uptake. So this is a plot where we break the population down into quintiles, so fifths, and we break them down by deprivation. So red is the most deprived areas and green is the least deprived, and this is looking at vaccine first dose coverage. And you can see that there's a disparity of about 10% in the over 50s, and this is data going up to the 14th of April. So obviously one of these quintiles has to have higher rates, and one of them has to have the highest rates, and one of them has to have the lowest rates. But it's quite clear through this gradient that it really does depend on deprivation. So the least deprived areas have the highest proportions of people being vaccinated, and you can see that actually if you break this down by age group, that the gap gets wider the younger the people being vaccinated get. So the gap is only 5% for people who are over 80, but by the time you get down to the 50 to 54-year-olds, the gap is up at 15%. So it's a concern that as we are vaccinating younger people, that this gap will continue to increase. And you can see that actually overall vaccine coverage has decreased over these different groups for first doses. So it's a concern that this inequality is going to continue to rise as we get down into younger and younger people who we're vaccinating. Breaking down vaccine statistics by ethnicity, again, you can see that there's inequality here. So white people, this is for over 50s in England, are vaccinated at a rate of 93%, whereas black people are vaccinated at just 65%, and there's a range in between there for people of different ethnicities. So ideally, we would be vaccinating everyone at the same rate, and we would see equal vaccination across different rates. Again, you can see if I break this down by age, that this gap exists across all age ranges, but it seems to be widening again the younger we get. So a 22% gap between white and black vaccination in 80 plus, rising to a 29% gap in 50s to 54s. So this is something we really need to keep our eye on and try to work hard to battle against, so that COVID doesn't continue to be a disease of inequality, so that we can make sure that everyone is equally protected by the vaccination. And the last couple of things I want to do are look at the situation in other places around the world. So just having a look at Europe, we've been hearing about the third wave that Europe is experiencing, largely as a result of having experienced the B117 variant from the UK. There's evidence that through stringent lockdowns, many of the major countries in Europe now have cases flattening off, although countries like France are seeing alarmingly high levels of cases still. And actually, this is daily new confirmed cases. It doesn't account for the size of the population. So if you look at cases per million population, then you'll see some of the countries that I've put in here, like the Netherlands, are in a particularly bad state in terms of the per capita rates of the disease. Cases are rising. The Netherlands is talking about opening up. They have no planned travel restrictions to or from India. So I think it's worth remembering that although it's sunny outside in the UK and it's nice and we think we're in a fantastic situation, and things are looking up, that actually this is by no means over. Even in Europe, if we look at the rest of the world, then I think we'll see that that's also the case. So here are a few selected countries. Again, this is cases of COVID-19, particularly I've put in Brazil here as a representative of South America. Cases have plateaued there at an extremely high level. And India, as a representative of the Indian subcontinent, cases are absolutely skyrocketing in India. And if we look at the number of deaths, although it looks like Brazil has the highest number of deaths corresponding to the high number of cases they've had, and they have had deaths around 3,000 a day, which is alarmingly high for a period of a couple of weeks now. There's reasons to believe that the estimate of the number of deaths in India is a massive underestimate. In fact, in some regions, it's supposed that it's an underestimate by a factor of 10, possibly. So the situation in India isn't entirely captured by this picture, but things are going south fairly quickly there, and it's becoming a genuine humanitarian crisis. Hospitals are overwhelmed, they're running out of oxygen, and death figures are absolutely through the roof. So I've seen suggestions in Britain that Britain is no longer in a pandemic, but I'm sad to warn you that that is not how pandemics work. And if you look at the number of cases confirmed across the world, they're at higher levels than they ever have been, and deaths are also creeping up to their highest levels ever as well. So by no means are we out of this situation, and we need to do everything we can to make sure that, as we say every week, nowhere is safe until everywhere is safe. And so we need to really try to make sure that we tackle this everywhere. And the last thing that I want to look at, because it's a hot topic at the moment, is variants. So I'm going to look at 4 main variants. So P1, which was first identified in Brazil, B1617, which is the one that we're concerned about in India. It's first identified in India. B1351, which is from South Africa, and B1525, which is the UK B117 variant with this extra E484K mutation. So usually when variants arise, we're concerned about 3 things. Do they spread faster? Do they cause more severe disease and death? And can they evade existing immunity? And so in terms of do they spread faster, B117 we know spreads significantly faster. P1, the Brazilian variant, is also shown to be more transmissible. But it's not yet been established whether the Indian variant B1617 or the South African variant are significantly more transmissible. In terms of do they cause more severe disease and death, we know again that B117 has been shown to be more deadly. P1, the Brazilian variant, and B1351, the South African variant, are thought to be more deadly. And B1617, the Indian variant, is probably too early to tell at the moment, although there are suspicions. Perhaps what's most concerning for us in the UK, given that we're vaccinating a large number of people and that people are suggesting that we're out of this, which I don't think is the right message, is perhaps that evading existing immunity. So we know that actually B117, the UK variant, is not very good at evading existing immunity. Our vaccines are very effective against it, whereas the South African variant B1351 is better at evading existing immunity, as is P1, the Brazilian variant, but perhaps less so than the South African variant. And it seems highly likely that the Indian variant B1617 is as well. So this is just a plot of the number of cases that are sequenced of these 4 main variants that I was talking about. And this data comes from COG, which is the COVID Genomic Consortium. They're sequencing positive test samples. We were told earlier this week that actually all positive test samples from incoming travellers are now being sequenced, which I think is good news. But what it does mean is that this data is unlikely to be representative of community transmission across the UK. So this is probably going to be biased. These absolute numbers that you can see, India, which is the Indian variant, which is the red one here, has taken off since the beginning of March, overtaking the South African variant in terms of absolute numbers. But actually, these absolute numbers aren't that helpful. It looks like everything has dropped over the last week, but that's largely as a result of the fact that not many sequences have been reported over the last week. So if you look at instead the proportions of sequenced variants that each one of these variants makes up, you can see that actually the South African variant has fallen, but only very slightly, and that B1617, the Indian variant, is taking up a larger share of the proportion of genomes that are being sequenced across the UK. So I think looking at proportions does give a clearer picture, although South Africa looked like it dropped. It actually hasn't dropped off that much, although P1 and B1525 look like they're struggling to gain a foothold, which is good news. It's hard to draw really firm conclusions from this data because I don't think it is representative of transmission in the community. Rises in B1617, the Indian variant, may just be a result of the high levels of COVID that we're seeing in India. 5% of travellers arriving from India tested positive at some point during their self-isolation period. So I want to show you just one last graph on variants. This is from Public Health England, and it is it's suggesting where cases that were sequenced came from, or were they associated with travel or not. So dark blue is associated with incoming travellers, light blue is contacts of travellers, grey is currently under investigation, and yellow is probably the most concerning, is no known connection to travel. So these yellow ones are probably the most worrying ones, suggestive of community transmission, but obviously at low levels at the moment. Obviously, India being placed on the red list as of this morning will make a big difference to the probability of importing this variant. But as soon as it spreads to other countries, as we've seen with the South African variant, it will be possible to import it from those countries that are not on the red list. And that goes back to Duncan's question of, is it sensible to talk about having a red list? It's also important to remember that we are tackling these current variants at a time when the reproduction number is below 1, so chains of transmission will naturally be broken, and this becomes a very different game as we start to open up and R rises above 1. And the other thing to say about the Indian variant is that B1617 is still only a variant under investigation. It's not a variant of concern yet, so cases don't automatically trigger surge testing. And I guess the most worrying thing is if we insist on waiting to find out whether a variant is a variant of concern, then by the time we actually find that out, then it may well be very concerning. So I'll summarise by saying good news is cases continue to fall. Vaccination is improving, but inequalities are getting higher, especially as we vaccinate younger people. The situation in the Indian subcontinent, South America, are still extremely worrying, and variants pose a significant threat to our so far excellent vaccination programme. So I'll stop sharing screen and I'll pass back to you, Alice. Thanks.
Thank you very much, Kit. Fascinating to see that European and international perspective there. So now we're going to take some questions from the press and public. And the first question is from George Arbuthnot of the Sunday Times. George.
Hello. Thanks a lot for that presentation, Kit. That's fascinating. The question I wanted to ask was, given the concerns about the number of variants that feared to undermine the vaccination programme, and given that we're about to open up and R is likely to go above 1 again, which presumably will lead the variants to spread across the country significantly more, how concerned are you guys about the prospect of being forced into another lockdown? Do you think that will happen? And if so, how long do you think it will take for us to get there?
Thank you very much, George. And Professor Susan Mickey will start with this.
I think if we don't do anything more than we're doing at the moment, there is a real danger of having another wave later on in the summer, the autumn or the winter. But there are several things that can be done that would minimise the chance of that and prevent having another lockdown. And these are issues we've talked about quite a lot on these sessions. The first one is to isolate people who are or are likely to be infected. So those who have symptoms, those who are testing positive, or those who are contacts of those who are infected. And that requires putting in the infrastructure and giving financial and practical support for people to isolate. A second thing is to ensure that settings are safe. So places where people go in numbers are safe. For example, workplaces, schools, shops, when they open up, hospitality. And that means ensuring really good ventilation in the first place and distancing where it can be done, and learning the lessons of last summer and ensuring that as much as possible happens outdoors rather than indoors. As the science has developed over this last year, it's become more and more apparent that the main transmission is through aerosols in enclosed indoor spaces. So those are just some of the things that we can do, and there are many others. If we can learn the lessons from other countries, learn the lessons of what we didn't do right over the last year, then we have the potential to avoid another wave and another lockdown. But it does mean the government taking the situation seriously and putting in these kind of measures.
Thank you very much. And Gabriel Scally, I think you wanted to comment, and then I'll come to Christina and Stephen.
I just want to make a comment, George, about one thing that we're still missing out on, and that is testing of the people most at risk. We're doing lots of testing, but we're not testing the people most at risk. And that those people are the close contacts of people who have tested positive for COVID-19. Now, amazingly, England and Wales don't test close contacts. Northern Ireland started testing close contacts just this Monday. Scotland started on the 18th of February. There's no word of England and Wales starting to test close contacts. Yet the Director General of WHO called for the testing of close contacts on the 16th of March last year. The European Centre for Disease Prevention and Control have it in their policy that close contacts, and in fact, we should be doing more. We should be doing backward tracing, which we're not doing. And CDC, Atlanta, perhaps one of the premier sources of advice in the world, has, again, another organization where its protocols indicate that testing close contacts is what we must do. And we just are not doing it. And therefore, for that and the reasons that other reasons that Susan has mentioned, it's inevitable that as we loosen things off, the hours should go up. But it wouldn't be like that if we were doing things properly. But we know test and trace is never being done properly, and it is really a criminal negligent system not to do what is known to be effective in this terrible situation.
Thank you, Gabriel. Professor Christina Pargle.
So I was going to say that too, but also in terms of the variants and their risk, if they're all susceptible to the vaccines that we're using in the UK, then you're basically looking at an increase in cases as we open up, as SAGE modelling subgroup kind of said, and that's almost self-limiting, because once everybody's vaccinated, then you should see that start to fall again. But the question is, how big is that going to be? And obviously, the lower the better, because it reduces infections and illness and death. And we can control that with the public health measures that Susan and Gabriel said. If you have a variant that can evade the vaccines that we're using, then in a sense, you're in a much more serious situation, because we have to revaccinate people with vaccines that as yet do not exist or are not licensed, although they are being worked on. And so I think one thing we do have to do is try and sequence as many positive cases as we can. So the UK COG is aiming to sequence all positive cases now that the caseload is quite low, so that's feasible. We should support sequencing across the world so that we absolutely can find out about variants quicker than we are now. So in India at the moment, there's just no evidence for sure about the variant B1617, but there are reasons to be worried. And one of them is that Delhi, which is kind of a major hotspot of COVID right now, in January, over 50% of the population were estimated to have antibodies against COVID from previous infection. And so for it to take off in the way it has taken off over the last month, and it's only like a matter of weeks in which it's got to this stage, it kind of implies that either it is a lot more infectious, or that it can affect people who've had COVID, or both potentially. So that's the worry, but we just have no evidence about it at all right now. And so unless we're kind of And since we sequence so much, if we're the first country that gets that evidence, then in a sense it's too late. So we have to contain it here.
Thank you, Christina, and Professor Stephen Reicher, and then Zubaida, I'll come to you. Stephen.
So the first point is nothing is inevitable. It's not inevitable there will be infections. It's not inevitable those infections will go away. And I think India is a very good example. And as Susan said, I think we can learn lessons from other countries. So the first question is, why did India not have that many infections last year? Why in the densely crowded slums like the Dharavi slum in Mumbai, one of the largest slums in the world, where there are only very few cases? And that showed that even in extremely unfavorable circumstances, really good public health can make a huge difference. So in each of the camps, they had doctors who went door to door to go and see people. They had mobile vaccination centres. They had huge amounts of information. They had special accommodation for people who were infected. They gave food and they gave resources so people could stay at home. So even in those circumstances, with good public health, with good test and trace, with supported isolation, they could stop the spread. The problem is they became complacent. In January, the health minister declared that they had contained and got on top of COVID. They lifted those restrictions. The government started campaigning for elections. It had mass rallies. It boasted about the size of its rallies. It allowed the Kumbh Mela in Haridwar, which was going to be in 2022, to be brought forward to 2021, this vast festival of about 5 million people coming together, densely packed. They forgot about those measures that had served them so well in Dharavi, in Mumbai, and so we see this massive spike. And so India shows us that if you do have good public health measures, you don't need to have a wave even when other places are having a wave. And it shows you that if you become politically complacent and you don't put those measures in place and you declare it's all over and you give a message to the population they can relax, then it can come back. And I think that's a very clear message and a very clear warning, which we need to take very seriously in this country as well.
Thank you, Stephen, and Dr. Zubaida Haq.
That was an excellent point made by Stephen. Lateral flow tests, George, are my biggest concern at the moment, because what we're seeing is, instead of a government that has learned from the past in terms of what works with suppressing this virus, both in this country and internationally, instead of learning from the last, 2 waves, what we have is a government that's tinkering with lateral flow tests. And it's tinkering with lateral flow tests as a substitute for the public health tools that we know that work. And that's extremely concerning. So we're seeing it right now in schools, where the government is running trials in a couple of hundred schools across the country without really consulting with the public or mentioning it to the media, where they're trying to substitute self-isolation with lateral flow tests. This is despite the fact that the MHRA in January said, no, you shouldn't be doing that. We haven't authorized that. It's not a good idea. So we've got that going on. And we also know that this government are trying to do the same with mass events that they want to happen in the next 2 months. Next 2 or 3 months, they want those to go forward, and they think that lateral flow test will be good enough to substitute masks and social distancing. And that's one of our biggest concerns. Not that we're against lateral flow tests. They can be a useful tool if they supplement the public health of test, trace, and supported isolation, but not as a substitute. And I think that's what we should be watching out for.
Thank you very much, Zubaida, and thank you for the question, George. Moving on now to a question from Graham Lawton of New Scientist. Graham.
Yeah, thank you for having me, and very informative as always. My question is this: the JCVI, the Joint Committee on Vaccination and Immunisation, has said that it's considering an autumn booster campaign in the UK, which would mean people who've been fully vaccinated already getting a 3rd shot. Do you think that might be necessary, and are there any dangers in that? Because we hear about this thing called original antigenic sin, which might become an issue with third shots. Has anyone got anything to say about that?
Who wants to start with the third shot then? I wonder if I could come to you, Professor Dinan Pillay, for a perspective on this.
Yeah, it's I'm hesitating because I don't think we know the motivation for a third dose is in a way thinking now about regular boosters. I think that's and it will be driven and is being driven by the concern of short-term durability of vaccines. And of course, you know, the very first vaccines were rolled out in the UK end of December, January. So 9 months later, we'll be in September. So, you know, and of course, we don't really know because we've not really got the data of what happens 9 months after a vaccine, because we've not lived through 9 months after vaccine rollout. And of course, UK was one of the first vaccine rollouts in the world. So I think it's a reasonable approach. It is a caveat to that, of course, is that many of the companies, the vaccine companies, are indeed working on vaccines to variants. And so I think we need to really look very hard at the degree to which breakthrough infections, in other words, infections that are now happening in those who've been fully immunized, whether that is because that these are new variants, and that will then determine the degree to which we really need new variant boosters rather than the original boosters. And just on that, I mean, this is a critical question. To date, I mean, there was a letter in the New England Journal, I think this week, about 2 cases of breakthrough infections and identifying that the breakthrough infection was with a variant that wasn't circulating earlier. But that in itself, that's the level of data we've currently got, which is clearly inadequate to determine a major policy. But that's, I think, the big worry. And that's the piece of data, or the pieces of data, we really need over the next few months, a really coherent assessment of what is the nature of breakthrough infections, and is that driven by variants, or is that rather to do with declining antibody and immunity from the first dose of the first 2 doses? Thanks.
Thank you, Dina. I wonder if you could also explain this phrase, original antigenic sin. What is that? Oh, sorry, you're on mute.
So antigenic sin is really is a sort of a definition of this is for the immune system to preferentially utilize immunological memory based on a previous infection when coming up against a new infection. So something about the original, the immune response being against the original stimulus, whether that is a vaccine or whether that's a natural infection or a vaccine. And so the question is whether coming up with a variant vaccine will actually stimulate the original antibody and an immune response, or a new immune response.
Thank you, Dinan. And Professor Anthony Costello.
Yeah, I think you raised a really important point, you know, this original sin, or, you know, freezing of the repertoire of your antibody response. That's basically is something that, you know, has happened with other viral infections, I think HIV and others, you know. I think this just reminds us that the idea that a vaccine is going to solve the entire problem is kind of wrong. You know, I've heard some journalists this week putting out saying it's all fine, we're all going to be vaccinated, and then, okay, there'll be a small number of people that get infected, maybe 30,000 deaths, no worse than seasonal flu. Well, that's wrong. That is actually 10 times worse than seasonal flu if you go on what virus you identify. And the idea that, you know, you can just solve it by continually boosting the numbers of vaccines is both logistically very difficult, and as you've correctly pointed out, it may actually be immunologically very difficult. So it comes back to the central problem of, are you going to have a suppression strategy, or a containment strategy. And the governments seem to be following the let's vaccine everyone, let's just contain it and see how it goes. It will just be endemic. Well, it could be endemic at a very high level that continues to overwhelm our health services, or certainly to so overload them that you're going to continue to have 4-year waiting lists, which we have at the moment for some forms of surgery indefinitely. So I think it is about our broad strategy. Vaccination has been great, but it's not going to solve the problem in its entirety.
Thank you, Anthony. And Dr. Tallulah Oni.
Thanks. I think I would add to Anthony's point that in as much as thinking about the local strategy has to be a comprehensive public health strategy, including but not exclusively vaccination, if we reflect on the presentation that Kit gave earlier, it's also an important reminder that the pandemic strategy has to be more than a local strategy as well. So when we talk about immunization and boosting and revaccination, it's also important to bear in mind what the opportunity cost there is, and globally, what is needed in terms of increasing vaccination access, where the progress has been much, much slower. And if there's anything we can see from the what's playing out, the tragedy playing out in India at the moment, is that we do have to do everything in our power, yes, to maximally suppress locally, but also to do everything in our power to support vaccination access globally. And that is a really critical point whenever we're talking about how to get out of this pandemic.
Thank you very much, Tallulah. And thank you for that question, Graham. Moving on now to Nigel Nelson from the Sunday People. Nigel.
Hi, Alice. Yes, this follows directly on from that. And it's about your call for patent waivers. If I understand it correctly, the issue in India is not the vaccines, because they've got a huge AstraZeneca plant there. But presumably there is a problem with getting drugs to treat COVID. Are there any drugs that we have a patent on in Britain that we could get rid of the patents and be able to help India out?
Thank you, Nigel. So quite a specific pharmaceutical question there. Would anybody like to take that? Have we got any perspectives amongst the panel? I'm going to have to come back to, I was going to pick on Deenan then, but Professor Gabriel Scally is going to answer it. Gabriel.
Well, Deenan can keep me right on this, but I mean, we've heard so little about the effectiveness of drugs for treating acute COVID-19 because there haven't been very many drugs seen to be effective. The most effective one, dexamethasone, is not a patented drug at all. It's been around for a long time and freely available and quite easily available. I'm not aware that there are any therapeutic agents that are of great value. But the one thing that are under patents and there's a problem of availability, the one thing that they do have enormous problem with in India at the moment is oxygen. And I know some of my colleagues have been very, very concerned about that issue, which is such a very basic requirement to the working of a hospital and particularly to the care of patients. And if there was one thing I was picking out in terms of therapy to help people in India at the present time, it is oxygen supplies, and whether the UK can assist in improving that supply as a matter of urgency, I think is something well worthwhile exploring.
Thank you very much, Gabriel. Anthony.
Just on the vaccine in India, just to point out, I mean, it's the Serum Institute in Mumbai that is generating most of the AZ vaccine under a mutual agreement. But there is massive capacity in India for producing vaccines. They're one of the biggest pharmaceutical producers in the world. And of course, most of the other companies that could produce vaccines are not able to do so under intellectual property issues. So it's a good example of where, India's 1.4 billion people, if they're going to vaccinate their whole population, which is in our interest as well as theirs, removing the patent waiver would go a long way to helping their capacity that is currently lying idle to be used effectively.
Thank you, Anthony. Has anybody else got any perspectives on this? How Britain could potentially help India? It was Stephen wanting to comment. Stephen.
So, I mean, certainly, I think all of us would echo what Gabriel said, that it is a desperate situation, and it's appalling to see the pictures and the stories of people who can't get into hospitals and who don't have enough oxygen. And I do think anything we can do to help must absolutely be done to help. And if it is possible to export the oxygen, then clearly that has to be a priority. But I don't think we should underestimate the issue of vaccines at a global level, because of course what's happening is, because India is using the vaccines now domestically, it's not then exporting them to other countries who need them. And when you look at COVAX as a whole, which aims to produce at the moment 187 million doses, which is enough for about 20% of coverage. So far, it's only got about 40 million doses, a quarter of that. So 20% of 20% is made available. So the overall story is very much that we need to increase the number of vaccines produced, not just distributed, produced. And there is capacity lying idle, and it is essential to waive the patents. When you look in the region, in Bangladesh, 10 million doses which have been promised, none have been delivered. When you look at Pakistan, 15 million doses which have been promised, none have been developed. So yes, the short-term acute need in India is desperate, and we've got to respond to that. But let's not counterpose that to the need globally to produce more vaccine, to waive the patents and make sure that other countries can vaccinate as well. Let's not counterpose the short-term, the medium-term and the long-term responses.
Thank you very much, Stephen. And I see that we have Labour MP Justin Madders with us. Justin, what's your question?
Yeah, thanks very much. And sorry, I actually missed the start of the presentation, so you may have covered this already, but I wanted to really just know a little bit more about the Indian variant. It's one of interest rather than concern at the moment, if that's right. So if someone could just sort of confirm whether that's the case, and also how much of it is being actually discovered in the UK. And then further to that, I've picked up quite a lot of issues with the testing companies who are doing the 2 and 8 day tests for arrivals back in the UK. Do you know whether those test results are also going into the sequencing process as well?
Thank you very much, Justin. So I think part of your question was covered in Dr. Kit Yates' presentation at the beginning, where he was showing the arrival and spread of the Indian variant. But I wonder if somebody from the panel could just elucidate there. Kit, I'll go straight back to you then.
Sure. Hi. So yes, it is currently classified as a variant under investigation rather than a variant of concern. Although I think all the evidence that we're seeing gives rise for us to think that it is concerning if it's not yet classified as a variant of concern. In terms of the numbers of cases coming in, they're still relatively low. We're talking in the hundreds here, like 100 to 200 at the moment. Yes, tests that come back positive are being sequenced. So people who are arriving and testing positive, those are being sequenced. The reason why it's difficult to know what the situation in the UK is in terms of community transmission is because we are massively biasing our sequencing towards travellers, people who are coming in and testing positive. So we are sequencing across the population, and hopefully we'll be able to sequence everyone that tests positive. But actually, we're quite biased towards at the moment people who are incoming travellers. So we're seeing a lot of these cases of the Indian variant. I showed a chart earlier which suggests that only about 3 of these cases have got no known link to travel. The vast majority are of people coming in who are travellers, or people who are linked to travellers. But there are a significant number of sequenced Indian variants who are still under investigation. It's still not confirmed whether they're related to travel or not, and I guess that's the concern. So it is concerning. I think we've seen that it's becoming the dominant strain in various areas of India, which suggests that it is more transmissible. There are concerns about it being able to evade existing immunity because potentially there are areas of India that have supposedly had higher levels of previous antibodies, and it seems to be ripping through those areas very quickly at the moment. So it is something that, even if it's not classified as a variant of concern right now, it is certainly a concerning variant.
And Martin, you wanted to comment here as well.
Just to emphasize that, and while we've actually been on the air, both Christina and I have had some data sent to us separately about India as a whole and West Bengal. And what is very clear is that the B1617 is really out competing all of the other variants and going up very rapidly indeed. And particularly, it seems to be displacing the B117, the Kent variant, which I think, although we need to look at this in more detail, is really quite worrying, or very worrying, actually.
Thank you, Martin and Zubaida.
Sorry. I think given what Martin has just said, which there were early indications of that, and given what Kit's saying about this whole process between variant under investigation to, identifying whether it's a variant of concern, and there's quite a lag between that. I'm really concerned that the only reason you get surge testing is when, or the only time you get surge testing, Justin, is when it becomes a variant of concern. And that to me is in itself concerning, because arguably by that point it's quite late. We have, I think, over 130 cases of the South Indian variant already across the country. What's also concerning is when you see where that's occurring, where there are high rates in places like London, the West Midlands, East Midlands. We know those are areas of high Black and ethnic minority groups and high deprivation, where there's already extreme vulnerability and risk. There's already high cases. So we could find ourselves in a situation where it spreads very, very rapidly, very quickly, like we saw with the Kent variant. So I think I'm concerned that it's not at the surge testing. And just to add one last thing, surge testing in itself is not the solution, because we saw from the surge testing of the South African variant in London that there were all sorts of problems where a lot of the emphasis and onus of responsibility for coming forward for the test, for ringing up about where to go for the test and so on, was all placed on the individual. So surge testing in itself also needs to improve.
Thank you very much, Zubaida. Dina, I'm going to come to you now, but I hope you could also elucidate something for me, which is, when does a variant become a variant of concern? What are the criteria that mean a variant is badged in that way?
Yeah, no, I wanted to sort of address this, and I think, I'm just going to give a little bit of a counter view to what the panel, many have said, is that this is an ever moving, target, and I think it took a lot of foresight to establish the network, particularly in the UK, but around the world, of genetically identifying COVID. This has not happened for any other infection so rapidly anywhere. And the technologies, it's a huge amount of very complicated work. It's not, anything equivalent to a sort of quick lateral flow test. It is a really a demanding sort of process. So, and it is only because we've actually been able to do that we've identified these variants that are happening. And of course, the definition, and there's so many we've got to get right as well, is that there's huge amount of variation of this genome, different mutations. There's thousands and thousands of these, and clearly there has to be a system for categorizing what becomes an important and what is not so important in terms of epidemiology, and that itself needs some structure, and that is where the variant of interest versus variant of concern developed. So in the midst of thousands and thousands of these small differences between the viruses, these lineages or variants of concern have emerged. But of course, the more we look, the more we see that. So I just want to place that into context. And of course, the going from a variant of interest to a variant of concern has become a sort of seen to be an administrative thing. But it's just, what is the meaning of these new variants? And also, it is the second thing is it is quite difficult to ascribe a burst of infection and a surge of infection, such as we're seeing in India. It's difficult to ascribe that purely because of this variant. These are really difficult things to show because, of course, there could be many other reasons why the infections are increasing in different parts of the world. I think Stephen has identified in India currently, in terms of mass meetings and so forth, why there may be a surge. So teasing these things out is difficult, and of course one needs a structure to do that. So basically, I'm just trying to place this in the context that this is a difficult thing, but I support the idea there should be more of this genetic characterization around the world. But the world's infections, maybe we have the sequence data of less than 0.05 of those infections currently, and it's still a huge effort. So it's a long way to go. So hopefully that places this in perspective. Having said that, of course, we're worried about what's happening in India. And I would suspect that this whole categorization, difference between variants of interest and concern, will evolve as well as we see these big epidemics, countrywide epidemics around the world in this second and third waves.
Thank you very much for that, Dean, and thank you for joining us today, Justin, and thank you for your question. Moving on now to questions from the public. We can squeeze in a few of those, maybe two of them, before we wrap up for today. The first one comes from Dr. Kirsten Ellis, who is Town Councillor for Hazelmere in Surrey. Kirsten.
Thank you. My question, the Education Secretary has announced that from May 17th, children and teenagers will no longer have to wear face masks in class. So with concerns about the Indian variant and other variants potentially posing greater risks to younger people, which is perhaps a point you could comment on, as well as existing worries about long COVID in children, why is this decision not being challenged or reversed? Also, in the US, everyone over the age of 16 is being invited to be vaccinated. So can the panel comment on whether we need to be doing more to protect our young people? Thank you.
Thank you very much, Kirsten. So first of all, we'll take that question on dropping the requirement for mask wearing in secondary schools. Obviously, there never has been a requirement in primary schools. Who would like to start with that schools question and mask wearing? Zubaida.
Thank you, Kirsten, for raising that question. It's extremely concerning, isn't it? Because it was just back in February when Boris Johnson said to us, look, it's not going to be just about dates, it's going to be data and dates. But what's become really clear is that the data bit has been dropped. And we know that because here we have Gavin Williamson, the Education Secretary, saying that masks is most likely to be removed in secondary schools without sharing any data about why. And this is going to be happening at the same time as everything opening up by May 17th. And that's hugely concerning that everything will open up. We've been told by the Prime Minister already that inevitably there will be an increase in cases, inevitably there will be an increase in deaths, although why that's inevitable, we don't know. Given that the Prime Minister has every tool at his disposal to make sure that that doesn't happen. But we know just before Easter, the infection rates went up among young people. They had the highest infection rates than any other age group. We knew that just before Christmas, each time before things close, whether it's for lockdown or whether it's for half term, the infection rates are really high. And before Easter, they were already wearing masks. And that's the really concerning thing, that even with masks on, it is spreading. So goodness knows what will happen when the masks are taken off. And at the same time, you've got everything else opening up. And as you say, we don't know about variants. We don't know how they're going to react with more transmission. So it is really concerning. And, we have been raising concerns, and we will hopefully be working, or at least talking to some of the unions and seeing where they stand on this as well.
Thank you very much, Zubaida. And then there was that second part of Kirsten's question, which was about the vaccination of over 16s in the US and whether that might be a strategy that will be adopted here. Does anybody want to comment on that? I'm looking around. Vaccination. I'm going to pick on you, Deenan, and then I'll go to Christina. Deenan.
Can you just repeat the question?
Kirsten, could you repeat that question about vaccination of over 16s, please?
Yes, absolutely. Yes, just saying that. So in the US, it's been announced that everyone over the age of 16 can step forward for a vaccination. So, it's basically the entire population over 16. Is that something that should be considered here? Is that? I'm just sort of putting it to you as a panel. What is your response to this approach?
Thanks. I'll make a stab at that, Kirsten. It's difficult. Clearly, we need to first of all just have the evidence that vaccines are effective and safe in younger people, and there's starting to be. I think Pfizer has data now that younger adolescents that is the case. But it begs a bigger question, which is about the degree to which young people contribute to transmission within the community, as well as, of course, themselves, having untoward effects. And what I mean by contributing to the ongoing transmission is that, we will always have some limitations in older people in terms of vaccine uptake as well as vaccine failure. And therefore, and as a panel, we've always thought, argued for going to a lower level of infection as possible. My view is that for those reasons, there are good reasons, but both for population protection of us all, but also because of protection of young people, that vaccination, if shown safe, should be extended to all. But there's, of course, there's limited data about that at the moment.
Thank you very much, Dean. And Christina, you wanted to comment here too.
Well, I think Dean has said almost all of it. Just on the Pfizer did release early results showing that 12 to 16-year-olds had really, really good response and almost 100% efficacy in a small sample and no adverse side effects. So that's really positive. I think the ONS surveys here have shown that about 10% of children can get symptoms lasting for more than 5 weeks, and I think even 5% more than 12 weeks. So I think there's a reason to vaccinate children to protect them, as long as it's proven safe. So, I mean, to me, it's when it's safe and regulated, we should do it. But that's my opinion.
Thank you very much, Christina. And I'm going to squeeze in one final question from Adrian Fayers in Essex. Adrian.
Hi there. Am I on screen? Yep.
You are, and we can hear you. Go ahead.
Thank you. Yeah, thanks for inviting my question. It's that with aerosols being the main mode of transmission, surfaces being the least important, and the easing of lockdown leading to complacency about social distancing, will it soon be time to change the order of the slogan to space, face, hands? Or if we leave as it is, to at least beef it up to hands, face, space, fresh air, and avoid the 3 Cs. And those who don't know what the 3 Cs are, avoiding the 3 Cs, it's a strategy that I think is working or has worked in Japan. And the 3 Cs to avoid are confined spaces, crowded places, and close contact settings.
Thank you very much, Adrian. Is the slogan right? Does it motivate the right kind of behaviour? Should it be fresh air, fresh air, fresh air now? Susan, could I come to you for an answer on that one? Yeah,
really good point. And I think that's absolutely right. The the biggest thing I think we can do over these, well, not the biggest thing, but a really important thing in terms of minimizing the chance of transmission is to ensure that in enclosed spaces, we get fresh air, whether it's, whatever enclosed space it is. And I think communicating that is really important, because recent data have shown that a large proportion of the British population don't understand that it's safer to be outdoors than indoors. Because the government has taken a very, very sort of rules-based approach, it means there hasn't been as much education as there could be and they should be going forward in terms of really people understanding about the methods of transmission and therefore what's going to undermine it. So absolutely, with the slogan, I know Professor Kath Noakes from Leeds, who's a world expert on the issue of ventilation, pushed very hard for the fresh air bit of that slogan to be added. I absolutely agree the order should be changed now, and maybe even better slogans come up. So really good point, and thanks for raising it.
Thank you very much, Susan. And Professor Carl Friston, you'd like to comment too?
Yeah, and relate that excellent question to the previous question as well. So, I've said this many times, and I'll say it again because I think it's a useful way to think about it. There are three things that cause transmission: contact rates, transmission risk, and the mean period of infectiousness. And that nicely demarcates or classifies the different responses we have. We've got the reduction in contact rates, which is a sort of national level response of lockdown, which is very, very different from reducing transmission risk through minimizing aerosol transmission, mask wearing and social distancing, which is very, very different from the local action that ultimately is aimed at isolating people and stopping them transmit the virus. So the roadmap is all about lockdown. It's all about targeting contact rates at a national level. That's going to go away, and it's going to be replaced by a focus on local action. And we've all heard many, many times about the requirements for enhanced public health approaches and ultimately going for the self-isolation. But I think most people, and certainly I, have been assuming that these two ends of the spectrum about the three kinds of mitigating responses will be rolled out in the context of preserved, COVID-aware, good behavior with persistent mask wearing, social distancing outside the 3 Cs for as long as this outbreak remains in the epidemic phase. I was assuming that would be in play, setting the context, countering fluctuations in transmissibility for months and months and months, if not years, until we reach the endemic phase. So that 3C thing sounds absolutely fine, and it should be, I think, more of a focus that this personal behaviour, this personal mitigating behaviour, sets the context in which lockdown can be relaxed as well if there is local action and enhanced public health responses.
Thank you so much, Carl, for that. And thank you for that question, Adrian. I'm going to draw things to a close for today. Now, last week, we skipped the usual summing up from the chair of Independent Sage, Sir David King, and many of our followers were utterly outraged at the omission. So, Sir David, please can I invite you, as our tradition dictates, for your closing remarks?
Well, Alice, thank you very much, and thank you for framing it to me with that comment. So, first of all, what I want to say is that we're a relatively small group of relevant experts, and we're open to the public to provide the best possible advice, and to government. And all of our advice is given looking forward. Take the present situation every day and look forward in terms of what is the best advice to give to government and the public from this point on. We've never been trying to analyse the faults in the past. We do occasionally wander into very critical comments, but perhaps that's not too surprising. So the point I just want to first of all make is that 12 of us, the same group of 12, have been meeting regularly over the past year, and we have gelled. I'm tempted to say we've matured over that past year into a group that really work extremely well together. And the hours that these people voluntarily put into this is really quite incredible. So I think that what I really want to say is as well, we learn from the exchanges with the public, with the media reporters, with the politicians who attend these public meetings. These aren't just us handing out advice. The questions are often very probing and very challenging, and we do have to think our way through each of these. So it is a process that has emerged over the past year, and I believe it has been successful. I am going to, as I always do, comment on one aspect of this, which is the failure of the find, test, trace, isolate, and support system that is acknowledged to be the right way to handle a pandemic by the World Health Organization, by all international bodies. And we still haven't got it operating in any way that would avoid us always going back into lockdown when the situation gets out of hand. So I think I'm just going to quote one of our colleagues from today, Gabriel Scally, who is appalled that we're not testing the contacts of people who have themselves the symptoms and have been tested positive. He actually described this as criminal. I would say it's simply amazing. I can't quite understand why the government and their advisors haven't understood the critical importance of this part of managing a pandemic of this kind. Thank you.
Thank you very much, Sir David, and thank you to all of our contributors today with their questions, and thank you to everyone watching, whether you're watching us live or catching up. Thank you to all of the independent SAGE scientists. As Sir David said, everyone here is a volunteer, and all the independent SAGE reports on all sorts of aspects of the virus and the pandemic are on the website, along with details of the scientists themselves. Please follow Independent Sage on Twitter if you don't already, and we're over on Instagram as well with the handle @IndependentSage, of course. We'll be back same time, same place next Friday. Stay home if you can. Stay safe. Keep well. Thank you, everyone.
Thank you.
Bye.